Over to you, Manoj. Manoj will speak to us on macular holes.
Thank you, madam, for giving me this opportunity. I'll be speaking to you on macular hole surgery and ode to the ILM. So some of the introduction slides have already been covered, but I'll just go through this. Now, in terms of macular hole, we all traditionally use OCT as a pre-operative tool. This is to understand how the hole is, and to understand how the vitreomacular adhesion is. So we have these gradings, grade 0, 1, 2, 3, and 4. And grade 1 is an impending macular hole without a full thickness hole as such. And grade 2 and 3 are holes with vitreomacular traction. And grade 4 is when there is a complete separation of the vitreous, and you have a any sized macular hole with a complete separation of the vitreous. And we also have the international classification group, which has classified holes into full thickness macular holes into small, medium, and large. So any hole which is less than 250 micron is called a small hole. Between 250 to 400 micron is a medium hole, and more than 400 micron is a large hole. So this is we need to do a preoperative OCT to understand the vitreoretinal interface and the size of the hole before we think of managing these patients. Kelly and Wendell in 1991 introduced this concept of vitrectomy for macular holes. And Eckart in the year 1997 introduced the concept of ILM peeling. And since then we have never looked back. We have a lot of modifications, and as Madam rightly said, this is one of the most commonest surgeries that we perform in our day-to-day surgical practice. Now this also Madam covered a bit in terms of what is the role of Muller cells. The Muller cells, the green, the central structure that you see there, that is the Muller cell. It spans across the retina, and this gives 50% of the retinal rigidity is due to the Muller cells. That's an important thing we need to remember. And the ILM, which we peel, is the foot plate of the Muller cells. It's like chopping off the legs. Now then what happens? The whole the whole retina gets a little unstable, and this increased retinal compliance helps us to close the holes. Also, the studies have shown that there is a reparative retinal glial proliferation that occurs after ILM peeling. So all these help us in closing the macular holes. Now if you look at meta-analysis, it is very clear that ILM peeling is very useful in stage 2 to stage 4 macular holes. But the question is, do you need to peel ILM in all cases? So the size actually matters. So for me, I look at the basal diameter of the hole. That's an important consideration for me. So when you have a small hole, or that is a hole which is less than 400 microns, you don't really need to peel the ILM. If you just do a good PVD induction, the hole closes by itself. And if you have a larger hole, more than 400 microns, definitely you need to peel the ILM. So that is one thing that has come out from the meta-analysis, that a large hole, you need to peel the ILM. We also have a lot of indices, the hole forming factor, the macular hole index, the diameter hole index, and tractional hole index. A lot of complex indices. You could use one of these indices which will suit your practice, and also take a decision on whether you are looking at a good prognostic hole or a bad prognostic hole. And if you're looking at a bad prognostic hole, definitely you need to peel the ILM. Now, Rahimi et al. Has also showed in their meta-analysis that in terms of reopening, though it's a very small percentage, reopening of holes are more in holes which have not undergone an ILM peeling as against ILM peeling. So all this are in support of ILM peeling for macular holes. Now ILM is a transparent structure, so to visualize ILM, we need to use a dye like ICG or trypan blue or brilliant blue to stain the ILM, and this, once you stain, it's just like the capsule, the anterior capsule. Once you stain these membranes, they get a little rigid and they become more breakable, and that is what helps us in peeling these membranes. So the usual technique that we do is a pinch and peel technique. As you can see in the video here, we are using an ILM forceps, the special forceps, the ILM forceps. So after you make this small defect in the ILM, you can grasp this edge of the ILM, create a small flap, and then this flap can be propagated. So this is one way you can start your peeling. You can also use the Finesis loop here. This is a wire-like instrument which you can use to kind of rub on the ILM and then create a flap. Or you could use an instrument like scraper. This is a diamond dusted scraper which is used to to peel the ILM. So you could use any of these instruments to start the peeling, and then you can propagate the peeled area with the forceps. Now, traditionally, we nowadays do the small gauge surgery. It's a little old surgery. This is a 23 gauge vitrectomy. We could do 23 or 25 or 27 gauge vitrectomy. The crucial stage is this PVD induction. The PVD induction is a very important stage. I always do not use IVTA, but in certain situations I do use IVTA when I think I'm not got this good V's ring when I do the PVD induction. After that, we inject brilliant blue dye, and then we start our peeling. So here, as I said before, I'm using the ILM forceps here to make that first defect on the ILM, and then the flap is raised. And once the flap is raised, now you kind of propagate the flap around the hole. There are some techniques. Some people like to go across the hole. Some people, with techniques like where you want to preserve the ILM around the hole for an additional procedure like tuck-in, you may need to go around the hole. And it's always better now to keep these flaps. I always try to keep these flaps long so that you get you can control the area of peeling. Area of peeling is also a little controversy. There is some controversy on the area of peeling, whether you should peel large or peel small. But here here you see this is a fairly good peeling that I've got. So this is, then you look at the vitreous base for any missed breaks, as Dr. Ashad was saying, and then finally we do a fluid air exchange and I inject gas. I like to use SF6 because it's a short tamponade. I put the patients on a prone position for at least 3 days now. So this is how we perform the surgery. So although there is widespread acceptance of ILM peeling, there is no consensus on how wide to peel. So the conventional peeling is around 2 disc diameters, and something which extends up to 4 disc diameters is called an extended ILM peeling. Now Mahesh is here. Their paper showed us that there's a similar closure rate with both small as well as large peeling, but in the smaller peeling eyes, they had better visual acuity, as against another group which showed that the extended peeling eyes had better visual acuity and better anatomical closure. So there is some controversy as to, I like to peel them less because, as Madam rightly said, we are slackening the retina. We do not know the long-term effects of this. We just need to peel enough to close the holes. So we have this Manchester large macular hole study which looked at ILM peeling in large macular holes. And they came to the conclusion that if you have a hole diameter of 400 to 650 microns, ILM peeling alone still is enough. So even for large holes, ILM peeling works well if it is up to 650 microns. Now if it is more than that, then the closure rate was inadequate. So then they suggested that you need to go in for an additional procedure. So this would be an indication for additional procedures. Michalewski et al. Introduced the concept of inverted ILM flap, where they tucked in these holes, and meta-analysis have shown that anatomical closure rates are better, and visual improvement is also better in these eyes. There are different ways of tucking in. Here what I'm doing is I'm trying to tuck in with the cutter itself. After making a small after pruning the edges, I'm just tucking in with the cutter itself. So you could do that. You can also tuck, this is an example of a large macular hole with this technique. You can see the ILM that is there. This is at 1 month and this is at 3 months. ILMs may be there for a long time, up to 6 months. You may still see these membranes, the ILM membranes sticking in the region of the hole. This is a type 1 closure. This is a tuck-in where I'm using a forceps. Now sometimes I would like to do it under air, because the flaps are, you can mobilize the flaps more easily, and sometimes I put a drop of visco there so that these flaps are still maintained there. So you could also do it under air, though the visualization is slightly difficult under air. This is a patient with 1,424 micron holes, which again shows type 1 closure. We have in our analysis, all these yellow arrows that you see, we did an analysis, and we found that it's a temporal portion of the hole which actually shifts. So more than the nasal, it's a more of a temporal portion. So like when you peel, it would be nice to peel more temporally than nasally, because that would allow easy movement shift of the retina to close the holes. You could also use PFCL here. PFCL also keeps the flaps in place, and it's very easy to kind of the visualization is also better, so it's easy to do it under PFCL. So meta-analysis have clearly showed that when they compared in large holes, when they compared inverted flap versus ILM peeling alone, they showed that there is a superiority of the inverted ILM flap in terms of anatomical and visual outcomes. Macular in 2015 introduced the concept of just a temporal peel, where instead of just peeling across the fovea, he just created a temporal flap and just left it there, and then did a fluid exchange. The closure rates were excellent. This is something that we sometimes do. Dr. Uni does this. He does his cabbage flaps, where he just prunes these flaps around the macular hole, and then without no tucking in, just does a fluid exchange after this. These holes also close excellently well. You can see the flap there. This is a type 1 closure at the end of 3 months. This is something that that I like to do for a little larger holes. I do a vacuum closing of the hole. So nothing different. After the ILM peeling, I peel across the fovea, and then I do a small fluid exchange right at the macular hole. And I believe that without any intervening tissues, these holes close better, and there's early drying in these holes and they close better. We had a paper this conference where we showed that it was as efficient as the ILM tucking. So the failure of macular holes is around 10 to 12%, and most of the time is due to persistence of the vitreomacular traction element, or inadequate removal or regeneration of the ERM. In such patients, definitely you need an additional procedure like a tuck-in. Now, in this patient, when you have a failed macular hole, definitely I would like to put in a PFCL, because with free flaps, I try to do a free flap to close these holes, and free flaps is very difficult. They're quite mobile, and therefore putting in a PFCL bubble and then taking these free flaps and putting them under the PFCL bubble and closing is a very useful technique. So also in retinal detachment. Now in retinal detachment, peeling under a PFCL helps to keep the posterior pole attached, and you can actually peel around the macular hole. So the success depends on what type of hole you're dealing with. In an idiopathic macular hole, the success rate is good, but in other situations, traumatic, myopic, and retinal secondary holes, the success rate is not so good, and that we have to keep that in mind. Like this patient now this is a thickened posterior hyaloid with a VMT. I did a vitrectomy and ended up with a hole. This is under oil. And with time, by around 4 months, you can see this epiretinal proliferation around the macular hole, trying to open up the macular hole even wider. So when I removed the silicone oil, I did a peeling and did a stuffing in, and now we have a closed hole. So to conclude, so any hole which is less than 400 microns, an ILM peeling is not really necessary. Between 400 to 800 microns, I would definitely peel the ILM. And for those which are more than 800 microns, failed holes, secondary holes, I would definitely use a flap-based technique, either tucking in or a temporal flap or one of these modifications. Thank you.
Thank you, Manoj. We'll have some discussion after Madam's talk.